Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota. Thank you all for joining us for today's Sleep Medicine podcast. Today's topic will be 45 years of the MSLT. Where are we now? Mary Carskadden first developed the MSLT in 1978. So the technique has been used in the diagnosis of narcolepsy for nearly 45 years. You might have expected that by now the performance parameters and interpretation of the test would be highly standardized, although there are several controversies that still exist. To discuss the MSLT in 2024, I'm joined today by my guest, Dr. Michael Silber, professor of neurology at the Mayo Clinic College of Medicine and Science, and a board-certified sleep specialist. Thank you, Dr. Silber. Mike, could you tell us about how important prior sleep deprivation avoidance is in interpreting the MSLT?
Thank you, Maitri. Yes, this is very important. It's not easy always to achieve, but it is absolutely vital for an accurate interpretation of the MSLT. We know that from a number of studies. If we go back as far as 1996, there's a very interesting study, only 11 subjects, but all of them were young people who said, I sleep adequately, at least 7 hours a night. And then they were instructed to increase their sleep time to 10 hours a night for a couple of weeks, and the MSLT was repeated, and the mean sleep latency over those subjects went up from, I believe, 6 minutes average to 11 minutes, and we suspect that even though they said they all slept adequately before, they were probably sleep deprived, and as soon as it was corrected, MSLT latency shot up. Another piece of evidence comes from the community-based Wisconsin sleep cohort, which you'll recall was a series of mainly middle-aged patients, subjects from Wisconsin taken randomly off the street, no preparation whatsoever. And one of the parameters they looked at was sleep onset REM periods on an MSLT. And they found that the odds ratio for developing sleep onset REM was dramatically increased when they were shift workers or when they just had less sleep than the average person in that cohort. So again, sleep deprivation with or without circadian rhythm abnormalities certainly affects the MSLT. So how do we go about it practically? Well, I'm pleased that in the revised 2021 parameters for the MSLT that the ASM brought out, they are a lot clearer that you really have to aim, if at all possible, for at least 7 hours sleep a night for 2 weeks before the study, including, of course, the polysomnogram night. The previous ones had this really controversial 6-hour rule, which was misinterpreted by everybody to mean you only needed 6 hours sleep, which wasn't at all what was intended, but now it's been clarified at least 7 hours, if at all possible. And we know that some patients with narcolepsy just can't always achieve that. So what do I do practically? I spend a lot of time on this. I talk to the patient and I say, for at least a week, preferably 2 weeks before the study, I want you to try achieve 8 hours in bed every night. So I extend it even further. And I don't say 8 hours sleep, because you can't tell anybody how long they sleep. That depends on their mind and their brain. But I say try get 8 hours in bed every night. And I really emphasize the night before they come back, because a lot of our patients at Mayo travel from a bit of a distance. So they may get up early the previous day to drive maybe 6, 7, 8 hours to get here, or to fly. I say if you're flying, take a day flight, not an early morning flight, not an evening flight. Be sure you've got adequate sleep, especially that critical last night before they come back to see me, before we go ahead with the study. During that time, I really want them to wear an actigraph if their insurance will cover it, which most but not all will. The sleep log is not enough by itself, at least in an ideal situation. Now, of course, there are some patients whose insurance won't cover an actigraph, and the question is whether you can use some other wearable, commercially available wearable. It's not the best because most of them you can't see the actual days, how long they slept. It's a sort of summative value, but it's certainly a second best if you can't have an actigraph and if they do have such a wearable. Then they come and see me and I check everything's okay. And then we do the polysomnogram. And I really emphasize it's important for everybody's sleep lab to have a separate protocol for pre-MSLT polysomnogram. So ours has do not turn the patient, do not disturb the patient, and unless there's some specific reason for it, and let them sleep in. So they try achieve a minimum of 7 hours sleep that night. Now, sometimes they just can't get there, but we let them sleep in almost routinely till 7 a.m. And some of our patients sleep in till 8 a.m. before we get them up before the MSLT. So we're living in a real world. We try our best. I go through all this, I write it down, and then the patient comes back and says, oh, well, there was a party that night 5 days or 4 days before. It was a birthday party to a relative, and I was up till 1 in the morning. And one just has to live with those things. You can't abort the whole thing as a result. Of course, if the person comes back and they've got 3 hours sleep a night the whole time, we do abort it. But we try our best to eliminate sleep deprivation.
That's all very helpful, Mike. Thank you for reviewing that. And really, I think helpful to hear how you address some of those practical issues in terms of actigraphy not paying, being paid for by insurance or dealing with some of the mishaps during the recording session. Another controversy is whether all psychotropic medications should be discontinued prior to the MSLT. Could you tell us a bit about what the data really show us in this regard and how important this is, and perhaps how you go about managing this?
Well, this is another really vital issue. Let me tell you about a study we did a little while ago under the direction of my colleague Banu Kola, who's both a psychiatrist and a addiction specialist as well as a sleep specialist. What we looked at retrospectively was a large number of our MSLT patients. Now, most of us at Mayo stop antidepressants 2 weeks at least before the study, but we did have a fairly large group of patients who, for whatever reason, the physician ordering the study at Mayo decided it wasn't in the patient's interest, and they went ahead taking REM suppressant antidepressants at the time of the study. And what we showed was when we looked for sleep onset REM periods, so REMs, we found those who had not discontinued the REM suppressant antidepressants found that only 2% of the cohort had 2 or more SOREMs, compared to 19% of the patients who'd tapered their antidepressants at least 2 weeks before. And this wasn't just a withdrawal rebound because they'd done it at least 2 weeks before. When we looked at who met narcolepsy criteria, it only 2% of those who had not discontinued the antidepressants met narcolepsy criteria compared to 13% of the cohort who had been weaned first. So yes, if you don't take them off the antidepressants, it's extremely hard to diagnose narcolepsy based on the SOREM criteria. Of course, they may still have a short sleep latency because generally we think the antidepressants don't have too much effect on sleep latency. Those sometimes are sedating, but we try our best to get them off. Now, obviously, if a patient's just been discharged from a psychiatric hospital following a suicide attempt, there is no ways that we're going to take them off an antidepressant. If they've got active epilepsy, we're not going to take them off sedating seizure medications. But generally, I personally don't do MSLTs. Then I try work things out in a different way and use other modalities, though that is controversial. But yes, we try to take them off. And I am so pleased to see that the new criteria state that on the MSLT report, the physician has to put what drugs they were on at the time of the study, because I so often see reports of MSLTs done elsewhere, and I have no idea what drugs they were on, and the patient doesn't remember. And I hope that people are starting to do that because it is really so helpful. So I take them off if possible 2 weeks before. For antidepressants, I discuss carefully with them their symptoms. If there's any doubt, I involve their psychiatrist. Many of the patients say, no, I've been on them for years. I'm sure I can come off safely. I've never had suicidal thinking. So I usually wean them to reduce the dose for a couple of weeks first and then discontinue and tell them contact us at once if your depression gets worse, or especially if any suicidal thinking comes up, and start it again, abort the whole thing. And we talk carefully about it. And I will tell you, I can get almost everybody off the sedating medications prior to the study. It's not fun for the patient, but it's doable. And if these are stimulants, amphetamines or methylphenidate or modafinil, we have to talk about probably not driving for the 2 weeks, possibly not working, and I give medical certificates so they can get FMLA or whatever else is needed to cover them over that time, but I'm generally successful.
That's very helpful, Mike. Are there any medications that you would hold for longer than 2 weeks
Hmm.
or perhaps shorter than 2 weeks? Are there any exceptions to
Hmm.
the rules, so to speak?
Yes, that's an excellent question. The classic one is fluoxetine, which has a really long half-life, and I try get them off for 6 weeks. Cannabis hangs around for a long time as well, at least on blood tests. How much it's hanging around the brain, I don't know. So we try get them off cannabis for a longer period than 2 weeks if we can. Shorter ones, caffeine, we try get them down on caffeine, and I'm usually pretty lenient on that. If possible, 4 or 5 days off before the study. The idea is to get them off 5 half-lives before the study. So sometimes we're more lenient. And again, it's a real world, and they come back and say, oh, well, I had a headache and I had to take something that had an opioid in it or something 3 days before. And we know it's probably out of the system by then. And we say, fine, go ahead.
Very helpful and very much the real world. So, diagnostic criteria for narcolepsy and idiopathic hypersomnia
Mhm.
in the ICSD-3 require a mean initial sleep latency of 8 minutes or less. Can you tell us a bit about where this number comes from, and is it really a valid cutoff?
Well, that is so interesting. You know, when the ASM came up with their first careful protocols for the MSLT in 2005, Donna Arendt, a psychologist who was very involved in all this, would chaired the committee and did an extensive review of all studies done on the MSLT before. And she found a 9 papers that looked carefully at the MSLT in patients with absolutely apparently proven narcolepsy. And there were 255 subjects in that joint analysis, and she found the mean latency on the MSLT was 3.1 minutes with a standard deviation of 2.9. So if you add 2 standard deviations to 3.1, you get 8.9, not 8. Um, then came along ICSD 2, and the people putting together the hypersomnia section, and I must admit I was one of the committee members there, came up with this 8-minute cutoff because we had to have some sort of cutoff. And to be quite honest, I can't remember the reasoning why we went for 8 minutes and not 8.9 minutes. But the text, I looked up in preparation for this for ICSD2, did say, be careful, perhaps 15% of narcoleptics will have longer latencies. ICSD-3, however, dropped that statement, even though it kept the 8-minute cutoff. So the vast majority of narcoleptic patients will have latencies, mean latencies of 8 minutes or less. But it is not a scientific cutoff. Nothing happens in the brain at 8 minutes. And I think we've got to use the MSLT as an extension of clinical method. And if the patient is classically sleepy and you feel this is what it is, and the latency is 9 minutes or even 9.5, it's still compatible and one doesn't cut it off. Now, some insurances may not pay for medication if they want that exact criterion, makes things difficult. But as physicians, I think we need to be lenient and realize that that is not meant as an absolute cutoff. Now, as far as idiopathic hypersomnia goes, this was simply extrapolated to IH without a lot of evidence at all. And of course, we know some patients with IH have even normal latencies, and that's why we have that second criterion of more than 660 minutes sleep done over the per day over the course of a week with unrestricted sleep, because there there are some people who have MSLT latencies with IH even greater than 10 minutes. So it's helpful as a cutoff, the 8, but it's not an absolute cutoff at all.
Thank you for sharing that. Also very helpful. So, as far as the ICSD-3-TR that now has a new criterion for the diagnosis of narcolepsy type 1, stating that if there's a sleep onset REM period on the preceding night's polysomnogram, an MSLT is no longer required to make this particular diagnosis. Can you tell us a bit about how valid this criterion really is?
Well, there's both an adult and a pediatric study. I'll concentrate on the adult study. The results are much the same. The adult study was a large study in multiple centers. It was published in 2013, and Alai is the first author. And for NT1 patients, they had 516 compared to 516 community controls, so an enormous study. They found that the specificity for that less than 15 minutes REM latency on the preceding polysomnogram was 98%, which is extremely high. The sensitivity was only 44%, so more than half patients who eventually ended up with a diagnosis of narcolepsy type 1 didn't have that REM latency, but 98% did, but the specificity was 98%. Very few people who didn't end up with that diagnosis of narcolepsy actually had SOREMs, and in fact, in the control, only 0.8% of the 516 control subjects had that short latency for REM on the PSG. So it looks it's both sensitive and specific, but we have to be careful to be sure that the study was done under good conditions, not suddenly stopping REM suppressant drugs the day before, and being sure they've got sufficient sleep at the time, just as we discussed earlier in this podcast. Again, I'd emphasize that in the Wisconsin Health study, which was just a random study of the population, there was only 0.4% SOREMs on the PSG, very low in the population. That was even a random population, and those who did have it correlated with insufficient sleep and shift work, the same things coming through and through. So yes, I think this is a valid criterion. If you suspect narcolepsy type 1, that clinically would mean narcolepsy with cataplexy, and your PSG done appropriately shows a SOREM, you don't have to go ahead with the MSLT to reach the diagnosis, and I think that's appropriate, but not for narcolepsy type 2. If there's no cataplexy, this data isn't so robust, and you should always go ahead with the MSLT, even if there's a SOREM, but you can count that SOREM as one of the two SOREMs for the purpose of reaching the diagnosis if there's only one SOREM on the subsequent MSLT.
That's very helpful, Mike. So I think really the take home point there is yes, you can use this new criterion, but when your clinical suspicion for narcolepsy type 1 is there. But if you randomly happen to stumble upon a sleep onset REM period on the preceding night's polysomnogram when studying the patient for something else like sleep apnea, then you really need to interpret that with caution.
With great caution, yes. I think that summarizes it very well, Maitri.
Do you have any final messages that you'd like to leave with our listeners today, Mike?
Well, yes, I'd say after 45 years, the MSLT is still a very helpful and valid tool for the diagnosis of disorders of hypersomnolence. But number one, it must be done correctly, precisely, and under very controlled circumstances, at least as much as the real world allows. And second, it must be part of clinical method. This is not like an isolated test. It's got to be integrated with the clinician's pre-test probabilities and likelihood and clinical acumen and experience, and you have to interpret it in that way. There are other ways of looking at narcolepsy, and in a subsequent podcast, we'll talk about orexin A in the spinal fluid, but we don't have a lot of other biomarkers, and until we develop them, I think the MSLT will continue to be done, and that's the correct approach, but as part of clinical method and done under very careful conditions. So I hope that's been helpful.
Thanks very much for sharing your expertise with us today, Mike.
It's a pleasure. We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.